Hi, I'm Dan Owens, and welcome back to the Pathology Report at Pathology Update 2025 in Melbourne, Australia. It's with great pleasure that we have two amazing haematologists to talk to us today about the bleeding and managing bleeding. We've got Dr PK from Melbourne, Victoria, and Beverley from the UK who's going to talk to us on those issues. And look, if I just first go to PK, with regards to our guidelines in Australia at the moment with regards to managing bleeding, do you think we've got those protocols right, or do you think they can actually be improved?
Yeah, thanks, Sam, for that question. I think like with all updates, there'll always be room for improvement when it comes to bleeding management. And certainly the update was quite overdue with the original patient blood management guideline, the original version being back in 2011. So it was well and truly due for a rehaul. Certainly in terms of metropolitan settings, some of the management protocols have been optimized, and there's a strong recommendation. So that guideline that was released in 2023, there was both good practice statements and recommendations as well, enforcing the need for all health services that deal with critical bleeding to have major transfusion protocols or major hemorrhage protocols in place. But I think the implementation step is always going to be a problematic area, and particularly more so in resource limited settings or more remote settings or rural regions as well. So while there's some good pertinent sort of management tips that came through, I think there's still some unmet needs and areas that we need to focus on. And I think that's hopefully the purpose of today's discussion that we'll have together as well.
Yeah. Do you think there are any adjuncts to what we currently do or recommend with regards to management, that like testing that could be additional to what we're doing, we recommend it to what we're doing?
Yeah. So, again, I mean, in addition to basic blood tests and standard sort of coagulation assays, certainly in the last few years, people have variables of familiarity and proficiency with using viscoelastic hemostatic assays as well. And I think certainly in my experience going through sort of my training as well, that was something that we were getting quite used to as well. But again, the process of being familiar with it and also setting it up, the implementation, the training perspective, and managing it also in remote settings is quite tricky. But that's one place where we think there will hopefully be a bit more of an evidence base in this sort of setting, but I think we'll probably need a bit more benefit of time and for some good data to come through to implement that as well.
You know, and so with active bleeding, say in the emergency department setting, in my experience, communication, it seems that seems to be a major part of getting it right with regards to what's required. I don't know what your experience is in your institution about integration of the patients, obviously patient healthcare, prime importance with the caring team in the emergency, and then the haematology support. How does that integrate in your hospital, and is that, could that be improved?
Yes, and we certainly released an update on our major transfusion protocol after, and really again plays the emphasis on having an appointed senior clinician involved in that, especially whether that's in a theatre case or emergency department setting as well, and implementing that also with the EMR system as well. It has its unique challenges in making sure things are communicated in a timely fashion. But I think as the haematologist or as the registrar there, I think you are that conduit, and there's a lot of responsibility that falls on that person to coordinate the relevant teams, the blood bank, what the clinicians want as well, and theatre staff as well. And it's in an ideal situation, you'd want that all to be nicely synchronized and streamlined. But as we know in the real world, it's not always the case. But certainly we review this every year or every couple of years to see that, and with changeover of staff as well, I think it's very important. Education is a big part of that as well. But certainly it can always be optimized, and I think that's one of the things that we emphasize every year with training.
Beverley, any comments?
So, I mean, you're really talking about a major hemorrhage protocol, aren't you? Yeah. And one has to damn the heart for the lack of evidence on how to use blood components. And it was really the trauma community in the last 10 years that have done the actual clinical trials to show that if you are resuscitating somebody, even before you get to do your routine testing as they're bleeding out, you need to give red cells and FFP in a 1-to-1 ratio. And the problem has been, since all that work, is that we have applied those principles across all areas where major hemorrhage occurs. And I think we've got to think much more about precision transfusion, because if you look at the data in someone with a GI bleed, you don't really want to give them too much fresh frozen plasma. There's evidence it worsens liver failure, and then postpartum hemorrhage is just developing in a whole new way of its own, and we shouldn't be using a 1-to-1 ratio, I think, with all the recent data. I'd like to highlight the recent data.
Yeah. Well, that raises a very, I think, an important area of supporting massive blood loss or massive transfer is the area of postpartum hemorrhage. So very keen to gain some learnings in from what you see as what we currently do and how or we might do and how that might be improved.
Well, I mean, I think back, and I was here in Melbourne in 2019 giving a plenary saying, can we please do some research in postpartum hemorrhage, because there were no trials and we didn't know what was happening to the hemostatic factors as patients bled out, and it's all happened since then. So I don't know if you're aware of the Collins family. So Peter Collins is the professor of thrombosis and haemostasis in Cardiff, Wales. His wife, Rachel, is an obstetric anaesthetist. And the population of Wales is 3 million, and they have put thromboelastography in every one of their 14 obstetric units and developed this protocol whereby we know that fibrinogen's the key player in obstetric hemorrhage. When it falls, you've got a problem. So they have said when someone is bleeding out, you need to run thromboelastography. And what they found was that most people had no evidence of a coagulopathy. So they wouldn't need to rush and get the red cells and FFP or whatever, but some of them had a low fibrinogen. And they treated them with fibrinogen concentrate or cryoprecipitate. And that policy meant that they saved a whole load of blood because they weren't transfusing women unnecessarily. And it just goes back to the fact it's very difficult with obstetric hemorrhage to identify how much has a woman bled, because a lot of it's internal. With trauma, it's easy. You see the blood on the ground. You see the patient who's shocked. It's all very visible, but in obstetric hemorrhage, it isn't. So what has happened is in the whole of the UK, we have a national improvement programme, and we're putting thromboelastography in every obstetric unit, one by one, to run exactly the same protocols. So that's how we will be managing obstetric hemorrhage in the future. And the other thing that he did, which no one had ever done before, they looked and measured all the hemostatic factors as the women bled out. And you had to bleed out about 5 litres before your level of factor 10 and the other factors got to anything that needed fresh frozen plasma, which is enormously useful information. I'll be presenting it this afternoon when I do a talk. So we can just sit back a bit with obstetric hemorrhage. We can do a TEG. They've got a normal TEG, then that's great. If they've got a low fibrinogen, we give them fibrinogen and we do serial TEGs and see where we end up, and they may need to go back to theatre. It's a very new way of doing things, and the FFP isn't necessary. It's a fibrinogen deficiency.
And the level of fibrinogen that's critical?
So the original French study was a level less than 2 grams. And, I mean, because at term, a woman who's healthy will have a fibrinogen, 5 to 7 grams per litre. So coming down from 5 to 7 to 2... it's a long leap, isn't it? There's quite a lot of blood that's been lost.
Yeah. Right. And so if we just move to the use of tranexamic
Yes.
Yes. I don't know if you've got any thoughts about that.
Well, yes. I mean, I was part of all the big trials, Crash 2 in trauma, and the woman's study, and also very useful in surgery. So my belief is you should use TXA in any bleeding patient, except the whole tip trial, which was in GI hemorrhage, gave TXA really for 2 days at a very high dose. And they were the ones that had thrombotic problems. Because as haematologists, we always think, I've given something prothrombotic.
Yeah, right.
So I don't think you are when you're giving an antifibrolytic.
Yeah.
So, I mean, you have the guru of fibrinolysis in Australia, Rob Metcalf. And, I mean, if you hear his lectures, he will tell you fibrinolysis developed millions of years before coagulation factors developed. They're very separate. If you give an antifibrolytic, you're not making a patient prothrombotic. So I think you can use it very liberally, or maybe I would say that because that's what my evidence supports. I agree we haven't done trials in really high prothrombotic patients.
Yeah, thank you very much for that. Now, I was just interested, PK. So, in your institution and your network, what is the utilisation of TEG and TXA in the postpartum setting? I don't know if you manage or look after obstetric hospitals in your.
I mean, one of the institutions that I work with do deal with obstetric patients and postpartum bleeding. Although we haven't set up viscoelastic hemostatic assays or TEG particularly in that setting. Partly because at that institution we don't deal with much trauma, but in other places where I've trained at, I have much more familiarity with TEG, where we do use it more for clear-cut trauma cases, and also with cardiothoracics being there, a lot of familiarity with rotum as well. So generally just viscoelastic assays in general. But certainly, irrespective of that, I think we're quite liberal in tranexamic acid use as well in postpartum setting. And I know in the recent recommendations, it was a very strong recommendation to implement tranexamic acid very early, within 3 hours of onset or identification of postpartum bleeding. And I think that's something that, we also continue to audit and monitor how we're going with those sort of outcomes as well. But certainly it's very dynamic. And, I mean, I like the concept of the viscoelastic hemostatic assays, especially compared to standard coagulation assays, where, we still try and recommend them to do frequent monitoring, but in the real world, it's easier said than done. But certainly, I think at our institute where we do have the obstetric patients, once we get a bit more familiarity, both from a clinician point of view, and we expand the role of the TEG, we may end up using that a bit more frequently as well.
And the assessment of blood loss in the postpartum hemorrhage setting, I mean, it is, as Beverley said, it's problematic, to establish that there's been whatever the blood loss has been, but what do we do and how can we do better in that?
Yeah, I think that's very difficult, as Beverley really pointed out. There's a lot of concealed bleeding that's there, and obviously we being at the interface as the hematologists, we're very reliant on our clinicians to guide us with that, and some of them might have already done some imaging studies, but a lot of this is a very dynamic process as well, And a lot of the time, we sort of ask them, is there any other better ways to do it? And we sort of get variable answers as to how to do about this, but it's probably a combination of the experience and the proficiency of the person on the other end, and also, their estimation of what's going on.
Any thoughts?
It's very difficult, I think, because most people overestimate bleeding with small amounts, and they underestimate bleeding when there's a large amount which might be sitting there in the uterus. So it's difficult, which is why if you have a TEG or a fibrometry measure there, it's giving you the reassurance that actually your patient hasn't bled out that much, or they really have bled out quite a bit. So I think that's the advice. We are actually using thromboelastography just to measure fibrinogen in postpartum hemorrhage, and coming through some tiny little machines the size of a smartphone that will just give you a fibrinogen. So we're testing them out back coast if they might be useful in that situation, because thrombelastography, the equipment's expensive,
Yes.
and the cartridges are expensive, and just to have one little thing that you could actually carry to measure fibrinogen might be the way forward.
And it might be the way forward in low-resourced
Yes.
areas,
Well,
both geographically challenged areas of,
Yes.
say, low-resourced areas, I suppose.
Yes, I think that, if we look at low-resource areas such as sub-Saharan Africa, where there is the biggest mortality from postpartum hemorrhage, extraordinary levels of postpartum hemorrhage, 1 to 2% dummy, extraordinary. And there is just no resource there, and they don't have access to tranexamic acid. So there's a big move from the WHO and from the charities to set up TXA factories throughout Africa so that it's available within various countries. That's a long-term plan.
Now, we, in our setting, so I'm in Tasmania, Melbourne, the UK, so the handling of TXA is, it's just, it happens, with regards cold chain or, whatever it is. So what are the requirements for TXA? Are there special things about having TXA in a low-resource environment that's going to be challenging with regards to handling it?
Obviously the issue is we're giving it intravenously. And many of the midwifery services do not have the ability to give it IV, so it'd be nice to give it IM. Coming through, there are some pre-drawn up syringes with 1 gram in, certainly in the UK, but you don't really need that because it's going to be on the shelf up there, whereas maybe in somewhere like a low-resource country, they might be more useful.
And I suppose in low-resource countries, not only is it going to be availability of TXA, availability of TEG, but also the availability of blood products and getting access to that in a timely fashion and training with regards recognising blood loss and which we have issues with recognising significant blood loss. So rolling that out globally is a challenge as well. So, do you see in the area of do you think that with regards issues around bleeding in low resourced areas, is it really postpartum hemorrhage or is it all no?
I don't think we've as yet discussed anemia. The high prevalence of anemia in women in those countries. When we did the woman study, we were a bit astonished to find that the average hemoglobin was about 80 to 90 grams per litre in some middle income country like Egypt, and then going to low income countries, lower levels of hemoglobin. And that's quite alarming because you need a normal hemoglobin to get a normal bleeding type. You use axial flow at a certain level, and it's just going to take longer to stop bleeding. So that's a major concern. And you see what happens really, that you have a woman who maybe has her first baby at the age of 15, has another baby the next summer, never quite repletes the iron stores. Every baby, every year, you get lower and lower iron levels. And the 4th or 5th pregnancy, she gets to term with hemoglobin about 60. And if her uterus doesn't contract, which is what tends to happen, then you're in real trouble. You're going to have a massive obstetric bleed. And looking at our data from the third world, people just bleed out, just sanguinate very quickly within 24 hours. Horrible statistics.
Sure. That speaks to the trying to have women as nutritionally robust before they get to before they become pregnant and do obstetrics deliver. For many other reasons as well, but particularly for having a good hemoglobin for delivery. So this means obviously there's work going on. I mean, we have great researcher in Melbourne, Pathology, who works closely with WHO and has done a lot of work in Africa with regards to nutritional deficiency. So a lot of work to do there. So it's interesting with regards, coming back to our Australian environment, that with regards iron, assessment of iron in pregnancy is only done when one is anemic. as looking for the cause of anemia, as opposed to considering or assessing iron deficiency as a pre-anemia, situation. So it's possible.
This is interesting. You can do a ferritin or measure of iron stores when they book it.
It's not part of the current.
It's not, but it sounds a good idea.
It sounds like a very good idea. Actually. Yeah, that's right. It's such an easy thing to do. And it's just not about the hemoglobin. It's all the other the tiredness, muscle effects with regards to iron utilization. So it has many other benefits as well. But yeah, it's interesting. So now, we've covered many topics. Is there anything that we'd like to bring to the table? Anything else I'd bring to the table? Talked about.
Yeah, I mean, we nicely touched about PPH and also about viscoelastic assays as well. And I suppose, we talked about management of bleeding, probably in more sort of regional remote settings. I mean, I don't have much familiarity with myself. All of my training's been here in metropolitan services, so I'd be interested whether either of you had any experience with dealing with more rural remote settings and how they can optimize that. And we're talking about critical, hemorrhage bleeding situations. Yeah.
Well, not in Tasmania. Well, in Tasmania, rural remote is 3 hours away.
Yeah.
But even so, not even that really. But yeah, so it's not that remote compared to, let's say, to outback, our regional, our remote communities in Australia, which I personally don't have any experience.
Yeah.
With that. How about yourself?
Not really. No, we're always near a hospital in the UK.
Yeah.
You're within an hour.
Yeah, that's enough. Now, one thing that we were fortunate to hear Beverley yesterday talk about things centrologic in the UK, but one of the issues that you raised was the cyber attack and I'm sorry to bring this up again, but it's probably not. Yeah, probably don't want to really. Would you like to raise it again with regards transfusion and it's sort of replicating? Yes. What do you do when you don't have the resources? You're in a high resource community. Yes. You suddenly become low resourced without access to all the.
So, I mean, to summarize, we had a cyber attack where we lost all pathology data and we were unable to support any results for any equipment into hospital systems. So in that setting, you recognize how much blood transfusion has changed. When I was doing my training, I used to have to at night be the blood transfusion technician, and I was always up all night cross matching, and the tests those days would take an hour, would have kind of changed. Whereas now it's all very sophisticated and you're utterly dependent on the electronic checking as you go through the process. And when you take away the electronic checking, we can no longer say it's safe when we manually cross-match. There's bound to be error. So in that setting, we said, okay, we have to just only use group O as the universal donor, so O plus O neg. And I mean, essentially the cyber attack took out 7 hospitals, and we have a lot of surgery, do all sorts of transplantation. So we had to continue, but we had to use O. And in that setting, we managed to totally deplete the national stores for Group O, and they had to have a national call out on BBC Network, please, at your Group O, can you come give some more blood? We have a national pop.
Can I ask, during that time, what happened with regards to obstetric services? But thinking about postpartum hemorrhage, and we imagined
They got O.
They got O, yep. So they were able to be supported.
Yeah, so I mean, we could operate in much the same way, but we only had O.
Yeah. And with regards to, we were talking about TEG and, the regular.
I mean, they were able to do all the regular services, but if they use blood, if it's, I think it's about 16 weeks.
And I understand that with regards patients in ITU, critical patients, they were potentially. Yeah, but were some of them transferred to hospitals?
When the cyber attack happened, they had no access to routine full blood counts, coag screens, and it took probably about 24 hours to get some semblance of the service back up when we would send out results by paper, or we had a team of people at the end, about 50 people, medical students, people from other labs in Europe who were just literally typing in all the results that full blood count into computer systems. We're using double data entry to minimize error. But it was a very slow process. And so that first 24 hours, we couldn't do any transplantation. We had some quite sick hemophiliacs who needed regular blood tests. We shipped some out, or we just refused to accept any new ones because we didn't have the support of the pathology system to be able to analyze their bloods. Just reminds you how important pathology is. Can't run a modern hospital service without a good lens.
Well, that draws to a conclusion our pathology report today. So thank you to our two guests, PK and Beverley. It's been a great pleasure to have your insights into bleeding and all issues, a lot of issues associated with that.